I'm Bruno Paiva from the University of Navarra in Pamplona, Spain, and I will be addressing how the definition of high-risk myeloma is evolving. First, I would say that the evolution is positive over the last decades, and I'm sure that the present decade between 2020 and 2030 will witness significant improvements in how patients with myeloma are staged and, importantly, how high-risk disease is defined, as the definition of high-risk myeloma should have, in the near future, immediate consequences in treatment decisions. In my opinion, the starting point to define high-risk myeloma is very effective, which is the revised International Staging System 3, based on the former R-ISS that relied on the levels of beta-2M and albumin, plus LDH levels and the presence of high-risk cytogenetic abnormalities, namely the 414 translocation, 1416 translocation, and or deletion of 17p. The outcome of patients with the revised ISS-3 is usually dismal, but it is true that other patients that do not fall into this category may also have short progression-free and overall survival. Therefore, there is room for improvement. In my opinion, there are two ways of improvement. One is to increase the accuracy of risk stratification at baseline before treatment, and the other is after treatment. Before treatment, I think that the current revised ISS will benefit from additional cytogenetic alterations, and there are groups such as the French, the IFM, that are truly leading the identification of high-risk cytogenetic abnormalities, and a few years ago showed how it was possible to develop a cytogenetic risk score and how this improves current models of risk stratification in myeloma. And I'm also aware that the European Myeloma Net is also aiming at improving the revised ISS by adding more cytogenetic alterations, such as in chromosome 1. Furthermore, I think it is important to evaluate tumor burden in terms of the percentage of plasma cells. Historically, the percentage of bone marrow plasma cells, defined either by morphology, the gold standard, or other techniques such as flow cytometry, has not been of notorious prognostic value. However, there is more and more data supporting a very important prognostic role for the quantification of tumor burden in peripheral blood. In other words, the assessment of circulating tumor cells, or CTCs. And we believe that CTCs can be a significant contribution and addition to the revised ISS. Therefore, these are possible ways of improving risk stratification and the identification of high-risk myeloma before treatment. And then after treatment, obviously, to assess MRD to continue reclassifying patients, as we should understand and recognize that in myeloma, risk is dynamic. And patients starting with standard risk disease may turn into high-risk myeloma because of persistence of high levels of minimal residual disease. And by contrast, patients with high-risk myeloma at diagnosis may enjoy long progression-free and overall survival if they are able to achieve undetectable MRD with high sensitivity, 10 to the -6, sustained over time, and probably not associated with immediate treatment cessation. Therefore, I do believe that the definition of high-risk myeloma is evolving. The evolution is very positive, and I'm absolutely sure that by providing better biomarkers to define risk in patients with myeloma, we will end up having individualized treatment in a few years' time.